Greetings, aspiring orthopedic clinical specialists. We are going to chat about the hip scenario for the next few minutes. And what we're going to do is we're going to go through the scenario. I'm going to give you some key points that I look at as I read the scenario. I'm a paper person, so I would highlight these points that I'm talking about, or at least circle them. And when I read a scenario, I'm thinking about items that might be asked, and I'm thinking about kind of three categories: examination, intervention, differential diagnosis, prognosis, or intervention. So I'm trying to glean information from the scenario that helps me possibly answer questions in those three areas. So the first thing I do, I look at this scenario, and patient's a 33-year-old man. Whenever I'm given an age, I pay attention to it. There are certain conditions that when you're given an age, there are certain conditions that should come into your head that you should say, here's my hypothesis. I'm thinking that these conditions are more likely than these conditions based on a patient's age. So that's the first thing I think of. When I see an age, there are certain things that are coming into my forethought and certain things that are going to the back of my mind. And same thing with gender. There are certain conditions that are more prevalent in certain genders. So I pay attention to that. We work in a fence factory. So I pay attention to that because we are performing probably some manual labor here. His complaint is 3 weeks, so I pay attention to that as well. How long have we had this pain? 3 weeks is different than 3 months. It's left hip pain after he fell. So now I know it's a traumatic injury, so that helps me a lot. We have some information that he was taking the trash out, he slipped on the ice. Okay, I'm reading that in my mind, as I first read this, I'm like, I don't know that that's going to make a difference, but they're just giving us some context to this. He talks about he may have done a split when he fell, but he's not sure, but he knows he landed on his left side. He also bruised his left shoulder. Okay, so we know this was a traumatic experience. He had a moderate, deep, sharp pain in that left hip that forced him to go to the emergency room. So we know it was pretty severe. So we're gleaning that information as well. And he found it hard to walk. And he fears he might have cracked something. He saw the emergency room doctor and they told him it was a sprain and they just gave him some NSAIDs. The sharp pain went away, but his hip got stiff and the pain became more aching in nature. So those terms mean something to us because I'm thinking about certain types of pain or certain conditions that those descriptors work for. Patient complains of pain in his groin and in his buttock. So again, that helps us a lot. Talks about it being dull. So that again means something to me. And he talks about what makes it better and what makes it worse. Those always mean something to me, whether it's position or whether it's activity. So he's saying sitting, lying down, standing for extended periods of time, that makes it worse. But we're also told that it doesn't increase with a cough or a sneeze or a strain. So that makes me think, okay, we're not dealing with lumbar spine issues or a disc here. So that information is really important. We're given past medical history. A tonsillectomy as a child, maybe not so important here, but we like to be thorough. He had an ORIF of his right humerus 15 years ago. Again, other opposite side, but we're still building a history here. And plain films were negative for a fracture or dislocation, and we're given current meds, which are NSAIDs. So we just went through and talked about all that information. That's kind of subjective information that we were given. The next piece here is the clinical examination. So all that information is important. I want to know what the subjective information is, what's used reporting, what makes it better, what makes it worse. And now we're going to get objective data here. We're going to get clinical information. So we look at, it talks about screening, and screening was negative. So that gives us really good information about what it is or isn't going on. And we have some hip range of motion here. We have some hip manual muscle tests here in terms of motions, in terms of how much motion we have and what motions may or may not be painful. We're given pain rating scales. And we have resistive tests. We're strong and mildly uncomfortable, all resistive testing. And all of the tests were negative for sensory, weakness, pain, anything like that. So when I see that, I'm thinking, okay, neurovascular structures are probably intact. The first question we're asked, which of the conditions are we most suffering from? So it's a differential diagnosis question. So we have to put all that information together. We have choices of labral tear, hamstring tendinopathy, traumatic arthritis, primary arthritis. So when we look at this, our age is 33 and we had a traumatic injury. So I'm probably not thinking primary arthritis. That probably doesn't make a lot of sense based on the symptomatology, the age, the presentation. Hamstring tendinopathy, not sure that makes sense, especially when we're told all resistive test is strong and mildly uncomfortable. If we had a tendinopathy, that would probably be a little worse. And a labral tear, we weren't given any information about any type of clicking or catching or anything like that. So I'm not really thinking a labral tear, although it was a traumatic injury. So maybe that's in the back of my mind. But when I see that traumatic arthritis, that's what comes to mind. This was a fall. He took NSAIDs, which seemed to help. His hip is stiff now. Those are descriptors, and that's symptomatology of arthritis, and especially when we're given the choice of traumatic arthritis. We know that this was due to trauma. So that is our best choice for that option. And now we're asked, what's our best treatment choice in question 2? So again, we consider all that symptomatology, and we've kind of figured that we have this traumatic arthritis. So what's the best way to treat this? We have an intra-articular injection. On the exam, you probably, that kind of choice is worded a little differently because as PTs, we can't always do intra-articular injections, but it's not saying that we're doing this as a PT. So in this instance, it's okay. So maybe you're thinking a steroid injection might help them. We're given joint-specific traction mobilization, resistive exercise, transverse friction exercise. The best choice here is going to be our joint-specific traction mobilization. Mobilization can absolutely help. If we looked at the specific range of motion limitations that he had, I didn't go into them because you can read them. This is going to be a capsular pattern. So a joint mobilization is our best choice here. Resistive exercise, we need to work on the range of motion deficits first before we get to resistive exercise. Transverse friction massage is not really going to be effective here. It's more indicated for, say, a tendinopathy, and even the evidence on that is not going to be as strong. So our best choice here is going to be our joint-specific mobilizations. Our next question, we have flexion limitations. So we were given those limitations in our clinical scenario. Flexion limitations can best be treated by pre-positioning the hip in flexion at the limit, along with which 2 other submaximal prepositions. So it's getting into an intervention question. It's getting into an open pack question. It's getting into a joint mobilization question here. So the best choice for this option is going to be abduction and internal rotation, because it puts the femoral head and it puts the joint in the best position to attack the capsule and to be able to emphasize the capsule, the force on the capsule, and to mobilize that capsule. So that's why that's our best choice. So that's just knowledge of anatomy and our open and closed pack position of the iliofemoral joint. And our last question, for what condition would high velocity, low amplitude maneuver be contraindicated as a primary intervention? So when I see that question, what I highlighted was contraindicated. It's asking me, when would it not be appropriate? Our choices are a labral tear, a loose body, an arthritic loose body, an idiopathic loose body, or osteochondritis dissecans. Our choice here is going to be osteochondritis dissecans. That is an intra-articular fracture. If we perform a high velocity technique on that, potentially that could be made worse. All of those other conditions, a labral tear, an arthritic loose body, or an idiopathic loose body, can actually be helped by a high velocity technique, and it can help to relocate a labral tear, or it can get a loose body into a spot where it's not going to be as symptomatic. So our best choice here for a condition that would be contraindicated would be osteochondritis dissecans. So we have to know our conditions, we have to know interventions, and what conditions those interventions are appropriate for, and what conditions they're not appropriate for as well. So this was a traumatic case at the hip, but it had a little bit of everything in it. It had differential diagnosis, it had intervention, a little bit of prognosis in it as well. So hopefully it helped us fortify some of those points and understand the hip a little better.